Hello everybody and welcome to this webinar coordinated by Philips, in which we're going to be looking at the use of high flow in the management of acute respiratory failure. We have two experts to talk about its use in hypoxemic and hypercapnic respiratory failure, and then I am going to give a short talk about infection control issues. Before we start, we would just like to get a rough idea of the expertise of the audience, and there's therefore a polling question for you to complete, and would be grateful if you could just quickly tick all that apply in your everyday practice. So a broad spectrum. I think hopefully there's something for everybody in this session. And without further ado, I'd like to move on to our first speaker, who is Professor Arnaud Thille from France, who's going to take us through the use of high flow in acute hypoxemic respiratory failure.
Ladies and gentlemen, good evening to everyone. It's a great pleasure to do this presentation concerning the choice of high flow nasal oxygen or non-invasive ventilation in acute respiratory failure. These are my conflicts of interest. The first question is, what are the alternatives to standard oxygen in acute respiratory failure? First, high flow nasal oxygen, and second, non-invasive ventilation using face mask, and maybe another interface, non-invasive ventilation using helmet. The most recent clinical practice guidelines were unable to offer a recommendation on the use of non-invasive ventilation for de novo acute respiratory failure. De novo means patient without underlying chronic cardiac or chronic lung disease, and the main diagnosis in this situation is pneumonia. We know the potential beneficial effects of non-invasive ventilation. NIV provides gas warmed and humidified, provide high FiO2 up to 100% without leaks, pressure support, decreasing work of breathing and PCO2, provides PEEP, decreasing work of breathing and improving oxygenation, and also providing beneficial cardiac effects. But non-invasive ventilation may also induce deleterious effects. For example, pore tolerance is frequent. Patient ventilator asynchronous are particularly frequent during non-invasive ventilation. NIV may delay the intubation by masking signs of respiratory distress, and may induce barotrauma in patients generating large tidal volumes. In this observational single-center study, the authors found that nearly half of patients generated large tidal volumes above 10 milliliters per kilogram. And in this situation, patients had an increased risk of intubation. This is the concept of patient self-inflicted lung injury, well illustrated in these two reviews. In the figure at left, this is the example of a patient with an alveolar pressure of 10 and pleural pressure of minus 15 centimeters of water. Alveolar pressure of 10, it's like pressure support of 10, and pleural pressure is the drop of pressure generated by patient effort. In this case, transpulmonary pressure is 25 centimeters of water, and transpulmonary pressure of 25 is the same value that in ARDS patients, the most severe ARDS patients just before ECMO, for example. Therefore, this is a very high transpulmonary pressure, potentially inducing barotrauma and increasing lung injury. High flow nasal oxygen has numerous beneficial effects, provides gas also warmed and humidified. There is good comfort thanks to nasal cannula. High flow providing high FiO2, providing also PEEP, but low levels of PEEP, around 2 or 3 centimeters of water, and providing washout of dead space, decreasing PCO2, and this is probably the main mechanism explaining the decreased work of breathing. As illustrated in this study, in this physiological study in 15 patients, they compared standard oxygen and high flow nasal oxygen, and they found decreased work of breathing using high flow nasal oxygen as compared with standard oxygen. They also find decreased respiratory rate, but tidal volumes remain stable without increase in tidal volume. According to the flow, the work of breathing decreases, and you can observe on this slide, patient effort, work of breathing using facial mask, high flow with a flow at 30 liters per minute, 45 and 60. And you can observe that the higher the flow, the greater the reduction in work of breathing. Surprisingly, the first large randomized controlled trial assessing high flow was performed before physiological studies, before to understand mechanisms explaining decreased work of breathing. And the first large randomized controlled trial was performed by Jean-Pierre Fratt in our unit in Poitiers, France, and was published in the New England Journal of Medicine. More than 300 patients with acute respiratory failure were included and randomized to receive 3 different treatments: standard oxygen, high flow nasal oxygen, or non-invasive ventilation alternating with high flow nasal oxygen. And we found significant decreased risk of death with high flow nasal oxygen as compared with standard oxygen or non-invasive ventilation. I would like to show you this table in the supplemental data. I think it's very interesting concerning comfort, because don't forget that this trial was performed 10 years ago, and centers had a very low experience in high flow nasal oxygen. And our hypothesis was that non-invasive ventilation could be the most effective strategy. And therefore, this trial was like a blind study, because due to the low experience of centers. But despite that, patients treated with high flow nasal oxygen had lower discomfort, and a higher proportion of patients treated with high flow nasal oxygen had a marked improvement of sensation of dyspnea. And they had also decreased respiratory rate as compared to standard oxygen and non-invasive ventilation. In a post-hoc analysis of this study, we found that patients who had large tidal volumes only 1 hour after NIV initiation had an increased risk of intubation and mortality. This probably reflects respiratory severity, but these patients with large tidal volumes had higher intubation and mortality rates than the others, and despite relatively low pressure support, 8 in mean, and PEEP in mean of 5 centimeters of water. Therefore, should we use non-invasive ventilation using face mask? I think that NIV in this situation may be potentially harmful, and especially due to large tidal volumes despite relatively low pressure support. Is helmet more effective than face mask? This is another question, because 4 years ago, this study was published in the JAMA, a single center study, including 83 patients treated with NIV with face mask or with helmet. All patients had IRDS criteria. And in this study, they found a decreased risk of death with helmet, and this could be due to different ventilator settings, because patients treated with helmet received lower pressure support, maybe decreasing lung injury, and higher PEEP levels may be promoting alveolar recruitment. In this recent physiological study, including 15 patients, they compared this time helmet with high flow nasal oxygen. And what did they find? First, oxygenation improvement with helmet as compared with high flow nasal oxygen. And they also found a decreased respiratory rate, decreased dyspnea, and decreased work of breathing. But they also observed an increased transpulmonary pressure. This was not significant in overall, but it was significant in most severe patients. And therefore, this could be deleterious within the next hours. This is a physiological study performed during only 1 hour, and we cannot predict effects at long term. And there is potentially a risk of barotrauma in this situation. Therefore, we need more studies concerning helmet and beneficial effects or not. Another situation is concerning immunocompromised patients. And although the experts were unable to provide recommendation for acute respiratory failure, they suggested that early non-invasive ventilation should be used for immunocompromised patients with acute respiratory failure. However, these recommendations were done based on previous studies, a small-scale sample, and the last, a large randomized control trial, a French study, found no difference in terms of intubation or mortality according to the use of standard oxygen or the use of non-invasive ventilation in these patients, these immunocompromised patients. Although they included a large scale sample of patients, more than 300 patients, intubation rates did not differ between the two groups. The study received some criticism because in France, we use non-invasive ventilation by short sessions, and therefore patients received only 8 hours of non-invasive ventilation within the first 24 hours. Therefore, we decided to conduct another study, including 300 immunocompromised patients with respiratory failure. And this study was coordinated by our center, and we randomized patients to receive high-flow nasal oxygen alone or high-flow nasal oxygen with non-invasive ventilation. But in this case, non-invasive ventilation was administered using prolonged sessions with a doses of at least 12 hours a day, using low pressure support to avoid patients' self-inflicted lung injury, and using high PEEP to promote alveolar recruitment. This trial has just finished, and unfortunately, I'm not able to provide the results. But in case of negative study, in case of no difference between the two groups, probably that it will be difficult to suggest the use of non-invasive ventilation even in immunocompromised patients. The last question, should we use really high-flow nasal oxygen in patients with acute respiratory failure? It's true that high-flow nasal oxygen is an interface, easy to use, particularly comfortable, and that seems safe and effective. However, to date, only one multicenter trial showed decreased mortality with high-flow nasal oxygen as compared with standard oxygen or non-invasive ventilation. And in a recent study, including immunocompromised patients, another French study, including nearly 800 patients randomized and treated with standard oxygen or high-flow nasal oxygen, intubation rates and mortality rates did not differ between two groups. And therefore, should we use really high-flow nasal oxygen? You have to be aware of some weaknesses in this study because not all patients had really acute respiratory failure. And second, 40% of patients who died had not been intubated before death, meaning that they had a do not intubate order. And I think this is a major weakness to conclude. To further assess high flow nasal oxygen, we are conducted a new study, the SOHO study. We plan to include more than 1,000 patients, all with acute respiratory failure. Patients will be randomized to receive high flow nasal oxygen or standard oxygen with primary outcome as mortality at day 90. What about patients with COVID? We have a few data on these patients and no randomized control trials. I would like to show you this first study performed in Italy when they had many patients, and therefore these patients with acute respiratory failure were treated outside ICUs. Italians use frequently CPAP, and therefore half of patients were treated with CPAP, 1/4 of patients with high flow, and the other with non-invasive ventilation. They observed more or less similar intubation rates, around 25 or 30%. Surprisingly, mortality rates were a little bit lower with high flow nasal oxygen as compared to the other strategies. And another study, a French study, including 146 patients treated with high flow nasal oxygen, they observed intubation rate of 56%, and mortality rate relatively low, 20%. And as compared to patients who were not treated with high flow nasal oxygen, mortality in this case seemed higher and intubation rates higher as compared with high flow nasal oxygen. Therefore, interesting signals in favor of high flow nasal oxygen. And concerning potential contamination, because at the beginning, nurses were afraid about the risk of contamination using high flow nasal oxygen, this study analyzed data in the literature concerning exhaled smoke dispersion distance using according to the different strategies of oxygenation, and the distance of dispersion was 17 centimeter using high flow nasal oxygen, only 10 centimeter with a mask, a simple mask, but 25 centimeter of water with a mask with a reservoir bag mask, and up to 40 centimeter with a ventilatory mask. And therefore, there is no increased risk of contamination using high flow nasal oxygen. In conclusions, NIV may be potentially harmful in patients with acute hypoxemic respiratory failure, especially in patients generating large tidal volumes. By contrast, high flow nasal oxygen is an interface, easy to use, comfortable, and that seems safe and effective. And maybe there is no really difference between immunocompromised patients and the others. I hope that our last study comparing oxygen and high flow nasal oxygen will provide results in favor or not of high flow nasal oxygen. But before to know the future results, high flow nasal oxygen is our best option for patients with de novo acute respiratory failure. This second talk concerns recent evidence regarding high flow nasal oxygen therapy. My conflicts of interest are the same as in the first presentation. The management of acute respiratory failure, I would like to detail 3 different situations. First, for pro-oxygenation of hypoxemic patients. Second, to prevent reintubation after extubation in ICUs. And then to treat respiratory failure in post-operative patients. We saw this study in the first presentation, management of de novo acute respiratory failure and the potential beneficial effects of high flow nasal oxygen. I would like to show you one more result in the supplemental data concerning oxygenation and PF ratio. As you can see, there was no difference in terms of PF ratio between high flow nasal oxygen and standard oxygen. And high flow nasal oxygen helps to improve oxygenation only by increasing FiO2, but not by increasing PF ratio. By contrast, in the NIV group, you can see that an increased PF ratio, an increased oxygenation in this group, despite worse outcomes at long term. In the subgroup of patients with a PF ratio below 200 millimeters of mercury, intubation rates were significantly lower with high flow nasal oxygen compared with standard oxygen or non-invasive ventilation. But as you can see, intubation rates range from 35 to a little bit more 50%. And in this case, what do we have to do before intubation of these patients to prevent severe hypoxemia? And the usual technique for pre-oxygenation is like that, with a bag mask, a reservoir bag mask with 15 liters of oxygen during 3 to 5 minutes. But we can also apply a non-invasive ventilation or high-flow nasal oxygen to improve oxygenation and to maybe avoid severe hypoxemia during the procedure. The potential beneficial effects of each technique, first with non-invasive ventilation, we can increase FiO2 up to 100% without leaks, and positive pressure may increase functional residual capacity. By contrast, with high-flow nasal oxygen, we could provide oxygenation during the procedure and during the apneic phase. And this is a potential interest of this technique. To explore the best strategy, the most efficient, effective strategy, we performed this randomized control trial, including a little bit more 300 patients requiring intubation in ICUs and intubated for acute respiratory failure with a respiratory rate above 25 and a PF ratio below 300 millimeters of mercury. And patients were randomized after stratification on PF ratio to receive high flow nasal oxygen with a flow at 60 liters per minute and a FiO2 100%, or non-invasive ventilation with a tidal volume around 6-8 milliliters per kilogram, PIP5 and FiO2 100%. The main outcome was the proportion of patients with severe hypoxemia, defined as pulse oximetry below 80% during the procedure. What did we find? There was no difference between the two techniques in overall population. As you can see, around 1/4 of patients had severe hypoxemia. But we found a difference in the subgroup of patients with a PF ratio below 200 millimeters of mercury. And after adjustment, NIV significantly decreased the risk of severe hypoxemia compared with high-flow oxygen therapy. This is the evolution of pulse oximetry with high-flow oxygen therapy in blue and non-invasive ventilation in red. And in the NIV group, pulse oximetry was higher at the end of pre-oxygenation and higher during intubation. This is the worst value in mean of pulse oximetry during the procedure. Therefore, NIV enabled preventing severe hypoxemia in these patients with severe or moderate hypoxemia, as compared with high-flow oxygen therapy. And I think it's in these patients, this strategy is probably the best efficient strategy to prevent severe hypoxemia episodes. What about after extubation? This is a Spanish study, a large randomized control trial, including more than 500 patients intubated in ICU and considered at low risk for extubation failure. There was a majority of patients, post-operative patients with short durations of intubation, and the authors found a decreased risk of reintubation with high-flow oxygen, only 5% versus standard oxygen, with a reintubation rate of 12%. The most recent clinical practice guidelines, however, suggested to perform non-invasive ventilation to prevent post-extubation respiratory failure and to prevent reintubation, but in high-risk patients, usually patients with underlying cardiac or chronic lung disease. The same Spanish group performed another study, including 600 patients, to compare high-flow oxygen and nasal oxygen with non-invasive ventilation in patients, this time at high risk of extubation failure. And they found no significant difference between the two groups. And in this condition, high-flow nasal oxygen could be a good strategy for all patients. But to further assess the best strategy, we conducted this study published last year in the JAMA. We including 650 patients at high risk of reintubation, meaning patients with an age of more than 65 or with underlying chronic cardiac or respiratory disease. Patients were randomized and received or high-flow nasal oxygen alone or high-flow nasal oxygen with NIV, with a first session of at least 4 hours and for a total duration of at least 12 hours a day during the first 48 hours following extubation. The main outcome was reintubation at day 7 after extubation, and we found that the use of NIV was associated with a decreased risk of reintubation in these patients at high risk of reintubation. NIV was delivered with a pressure support of 8 in mean, PEEP of 5, and for 13 hours in mean within the first 24 hours. NIV was applied and continued or not according to patient respiratory status, because some criticism could be that NIV during 48 hours is particularly prolonged and could be delayed discharge of the patient. And finally, in 1/4 of patients, treatment NIV was stopped early and patient was discharged. And by contrast, treatment was continued beyond the first 48 hours in 1/4 of patients. And therefore, this strategy could be adjusted according to patient respiratory status and continued or stopped earlier according to recovery or not. Therefore, in post-extubation in ICUs, patients at low risk of extubation failure, in this case, high-flow nasal oxygen could be an interesting and effective strategy to prevent reintubation. Probably we need a second large study to confirm these results. And in patients at high risk of extubation failure, I think NIV is the best choice, the best strategy of oxygenation to prevent reintubation, but maybe with high-flow nasal oxygen between NIV sessions, as we did in our study. Lastly, for postoperative patients, we can probably separate two situations. First, to treat mild or moderate hypoxemia with expected intubation rates around 10 or 15%, and to treat actually established respiratory failure, meaning patients with hypoxemia, but also with clinical signs of respiratory distress and high respiratory rate, and with, in this case, expected intubation rates ranging from 30 to 50%. After abdominal surgery, this large randomized control trial, a French study, included nearly 300 patients to receive or NIV or oxygen, standard oxygen. Patients were randomized and had really respiratory failure occurring within the first 7 days after a surgical procedure. They had hypoxemia, they had high respiratory rate or clinical signs of respiratory distress. And in this case, NIV significantly reduced the risk of intubation as compared with standard oxygen, 50% with oxygen and 39% with NIV. The question is, between NIV sessions, maybe high-flow nasal oxygen could be used between the sessions to improve oxygenation, but to date we have no data comparing NIV with high flow between NIV sessions or NIV with standard oxygen between NIV sessions. In patients with mild or moderate hypoxemia, but now without established respiratory failure, this study was published 5 years ago in 6 ICUs, more than 800 patients, comparing high-flow nasal oxygen versus non-invasive ventilation after cardiac or thoracic surgery. And this was a mixed population at risk with cardiac dysfunction, obesity, patients who failed spontaneous breathing trial failure, patients with hypoxemia, and some patients also with clinical signs of respiratory distress. And what did they find? That intubation rates were strictly similar, 14% in both groups in this population, as you see, with a PF ratio around 200 and with moderate elevation of respiratory rate. Therefore, in postoperative patients for grade 1, meaning to treat hypoxemia, high flow nasal oxygen could be used instead of NIV or CPAP. But in grade 2, to treat established respiratory failure, patients with clinical signs of respiratory distress, NIV remains the best strategy, the most effective strategy, but maybe with high flow nasal oxygen between NIV sessions. In conclusions, high flow nasal oxygen alone is probably interesting for treatment, for management of de novo acute respiratory failure, to treat postoperative patients with mild or moderate hypoxemia, but also to prevent reintubation in patients, in ICU patients at low risk of extubation failure. But NIV remains the best efficient strategy, maybe with high flow nasal oxygen between NIV sessions. First, for pre-oxygenation of hypoxemic patients. Second, for postoperative patients with actual established respiratory failure, and to prevent reintubation in patients at high risk of extubation failure. And as you can see, it depends of the timing. High flow for management of de novo acute respiratory failure, but NIV in case of intubation for pre-oxygenation before intubation in these patients in case of failure of non-invasive strategy. And first, to treat postoperative patients with mild or moderate hypoxemia, but in case of respiratory failure, these patients may benefit from NIV. And to prevent reintubation in patients at low risk, but with NIV to prevent reintubation in patients at high risk of extubation failure. Thank you very much for your attention.
Thank you very much, Arnaud, for those two great talks. I think that, just to say, fantastic research studies that you and your colleagues in France have done, really adding to the understanding in this area. We're now going to go on to Thille Braunlich, who's going to talk about hypercapnic respiratory failure, and we'll come back to discuss some of the questions that have been raised right at the end. So, Jens, over to you.
Thank you very much for the opportunity to present some data about nasal high flow and acute hypercapnic respiratory failure today. My name is Thille Braunlich from Germany, and I work on the University of Leipzig and Klinikum Emden. First of all, I will give you an overview why we think nasal high flow is beneficial in patients with acute hypercapnic respiratory failure. And the first data about this fact we have from 10 years ago in chronic hypercapnic COPD patients. We measured in these patients an increase in tidal volume and decrease in respiratory rate and then decrease in minute volume. And after 8 hours of use of a nasal high flow device, we found also in patients with pulmonary fibrosis and with COPD a significant decrease in PCO2. That's why we conducted a study in the same patients 10 years ago on the left side, where we compared nasal high flow with non-invasive ventilation in chronic hypercapnic COPD patients over 6 weeks each in a crossover design. And we find in terms of PCO2 decrease, quality of life, 6-minute work test, and so on, comparable effects of nasal high flow and non-invasive ventilation. In another study from Denmark, published in 2018, the colleagues investigated patients with COPD, hypoxemic and hypercapnic with stable conditions over 12 months, and they recruited patients from the out clinic area and treated these patients in a randomized order with nasal high flow or with standard oxygen over 12 months. And the data were published in 2018, and the primary endpoint was exacerbation rate. In the study, we found a non-significant difference, but a trend to lesser exacerbations if the patients use a nasal high flow device. Now we have a post-hoc analysis from the study it's now in press, where hypercapnic patients were analyzed from the study group, and the colleagues found a decrease in patients who used the nasal high flow device and also stable exacerbation rates in nasal high flow device compared to these patients who have no nasal high flow. They had an increasing exacerbation. Now I want to show you some data about patients with acute hypercapnic respiratory failure. If we look to the studies, we have only a small number of studies with very heterogeneous quality and design. We have some information about the use of nasal high flow alone without any control group. We have data about nasal high flow versus oxygen, nasal high flow during NIV breaks, and some small data about nasal high flow versus non-invasive ventilation. And one study about the use of nasal high flow alone in patients with acute hypercapnic respiratory failure comes from our group, published in 2018. We used nasal high flow in patients with naive COPD, with or without an acidosis. The patients with an acidosis were treated first with non-invasive ventilation. And if the non-invasive ventilation was not tolerated, we switched to a nasal high flow device and we treated these patients 4 hours. On the left side, you can see the whole group, patients with intolerance of non-invasive ventilation and patients with no acidosis. And we found after 4 hours an increase in pH and a decrease in PCO2. This was also true in patients with an acidosis and intolerance of non-invasive ventilation. After 4 hours, we had an increase in pH and a decrease in PCO2. But in this study, we had no control group. There were also no control group in this study from 2015. Young and colleagues investigated patients in the emergency department with a respiratory failure. It was a retrospective study design and looked for patients with hypercapnia and non-hypercapnic patients. All these patients were treated with nasal high flow. In the demographic data, you see there were a lot of patients with a chronic pulmonary disease and an acute exacerbation of COPD, but also patients with pneumonia, pulmonary edema, and so on. And they analyzed the data per group. The hypercapnic group showed a decrease in PCO2 and an increase in pH, but in the non-hypercapnic group, we found no differences in terms of PCO2 and pH. There is another very interesting trial from Thille, published in 2018. In this study, 45 patients were randomized to use nasal high flow in breaks of non-invasive ventilation and oxygen also in breaks of non-invasive ventilation. There are 23 or 24 patients included in the analysis. In the study, only a part of these patients were really hypercapnic, but the study is very interesting in terms of compare these two non-invasive ventilation strategies. And they found a change in respiratory rate compared to standard oxygen if they use the nasal high flow therapy, a better dyspnea score if they use nasal high flow, and a better comfort score compared to standard oxygen in this group. This is a very interesting idea, and we are waiting more data in a bigger study about this therapy. A very interesting study where non-invasive ventilation and nasal high flow were compared in acute and moderate hypercapnic respiratory failure comes from Lee et al., also published in 2018. And they recruited 53 and 46 patients in every arm and analyzed 88 patients. The patient used non-invasive ventilation or nasal high flow, and the group found that included patients with very different diseases. For instance, 42 patients with pneumonia, but also patients with congestive heart failure, pulmonary embolism, and upper respiratory tract infection. But all of these patients had hypercapnia. And in the analysis, they had the primary endpoint, the intubation rate, and the cumulative survival rate. They found no differences of intubation rate and survival rate for these two treatment arms. And the primary endpoint showed no differences in intubation rate and in the cumulative survival rate between these two devices. Another study comes from Sun 2019, and they used in a retrospective study design nasal high flow also compared to non-invasive ventilation in patients with a COPD, and they recruited 90 patients with a pH between 7.25 and 7.35 with a PCO2 more than 50 mmHg. And they randomized the patients in group with nasal high flow and a non-invasive ventilation group. And the primary endpoint was the failure rate in these both groups and the survival rate after 28 days. And they found also a comparable result between nasal high flow and non-invasive ventilation in this study. Another study, and this is the last study for this topic, comes from Majanovic. In 2020, they investigated patients in the emergency department with acute hypercapnic respiratory failure in terms of cardiogenic pulmonary edema. And they found also comparable effects of nasal high flow and non-invasive ventilation, and also a comparable decrease with no difference between these both devices in terms of PCO2 decrease. But what we need in the future are well-designed big data about the fact if nasal high flow is beneficial in this patient group. And we are waiting some data from a trial from Cordigiani, which I think so must be finished now. They randomized patients to nasal high flow and to non-invasive ventilation and looked for a non-inferiority in terms of blood gas analysis in the study. And they included especially patients with a pH between 7.25 and 7.35 and a PCO2 more than 55 mmHg. We also study in our country, in Germany, with more than 30 centers, and we want to show if nasal high flow is able to be non-inferior in terms of intubation rate in patients with acidotic acute exacerbation of COPD. This study will start soon, and we will recruit more than 700 patients in this study, and I hope we will have results as soon as possible. Another very interesting idea comes from the co-speaker in this session, published in 2019. They used nasal high flow and nasal high flow plus non-invasive ventilation in patients with a high risk of exacerbation failure. And he looked in the study for the reintubation rate. And they found lower reintubation rate in patients who used both devices compared to nasal high flow alone. But especially in hypercapnic patients, they found also better reintubation results if they use both devices. This is a very interesting idea, and I hope we have more studies in the future about this fact in acute hypercapnic respiratory failure. And I will thank you for the attention in this session.
Thanks very much, Jens. Again, a great presentation and very interesting data in an important topic area. The final presentation is going to be by myself. I'm going to be talking about infection issues, really from what we can learn from COVID-19. And I would stress that this is not an area where I have particular expertise, but I have studied the literature in some detail recently and share my reflections on it. Obviously, at the moment, the whole issue of COVID-19 is very much on everybody's minds. I think some of the lessons that we can learn from it are important in the use of nasal high flow in other conditions in the ICU, but I'm very much going to focus really on COVID-19. And the key question is, does nasal high flow increase the risk of infection to others? Because it was certainly true that in the first wave of this pandemic, in a number of countries, there was considerable reluctance to use nasal high flow because it was deemed to be aerosol generating and putting others at risk. And I think it's now timely to review this issue and the evidence. And I think the first thing that we need to consider is how respiratory viruses are transmitted. And this is a figure from a paper that I'm going to mention later from Dan and Lee, looking at the different ways that respiratory viruses can be transmitted, either through direct contact, through indirect contact. This is droplets falling onto surfaces that are then touched by somebody else, through to droplet and airborne transmission, and we'll discuss that in a lot more detail in a minute. And then also the importance of procedures that we do that generate aerosols. So in particular, intubation, bronchoscopy, anything that makes a patient cough. And these terms are used a lot, aerosols and droplets, and it's really important to understand what each of them are and how they're generated. Both are generated by flow disrupting the respiratory tract surface lining fluid, causing particles of it to break away and to be dispersed into the air. Generally speaking, small particles less than 5 microns are considered to be aerosols, but a very recent editorial in Lancet Infectious Diseases has suggested that perhaps a threshold of 100 microns is more reflective of the behavior of airborne particles, and that particles falling within the range of 60 to 100 microns are those which are going to fall to the ground within the 2-meter distance that certainly in the UK is recommended that we keep from other people. I have to say this editorial was about really the distance, that it was more about transmission in the community rather than in hospital and intensive care, but even so, it's an important point. The key message is that particle size is really important in interpreting the data. It also is important to realize that this is a continuum and that particles can move on this continuum. So for instance, something that starts as a droplet in the air, as it evaporates, will get smaller and may therefore move towards the aerosol end of the spectrum and behave more like an aerosol. Basically speaking, aerosols are produced deeper in the lungs. Because they're very small, they stay in the air longer. And when talking about them, this is when we use the word airborne transmission. Because they're small, they contain smaller numbers of viruses. It's just a simple fact of physics that they can only pack so many of a certain size in. And it's for these that we use FFP3 masks. Droplets, by contrast, are thought to be produced in the upper airways. Because they're heavier, they fall to the ground or onto surfaces quicker. But they can also travel further. If you think about bits of dust, if you're trying to blow it, a tiny bit of dust just doesn't go very far. It just sort of wafts up into the air. Whereas if it's a bigger bit of dust, you can blow it further. Because they're bigger, they contain more viruses. And when talking about them, this is what we're talking about as droplet transmission. And to protect against droplets, you need FFP2 masks. And one of the key questions is, what size particles does nasal high flow produce? Now, because nasal high flow is blowing air and oxygen across the upper respiratory tract, one might expect that it's going to produce more droplets than aerosols. Now, that's a theoretical consideration, but one that I think is very important. This was the article that I just mentioned, but I'd also mention this one, these 2 very good reviews about transmission of respiratory viruses with particular reference to SARS-CoV-2, and I'd strongly advise you to have a look at those. So first of all, what's the evidence that nasal high flow increases the risk of aerosolization, droplet formation? And this is a systematic review published earlier this year, first author Agarwal, and there were 5 studies that they included, either in healthy adults or using a simulator, and 1 in critically ill patients, but with gram-negative pneumonia, which will be significantly larger sized particles than we expect with viruses. And the authors concluded that basically there was a very low certainty of evidence, and I think we need to bear that in mind. They felt that the evidence was mixed-ray droplets, and with regard to aerosols, the 2 simulation studies showed no increased risk of dispersion, but 1 reported that higher flow rates was associated with increased regions of aerosol density. And in their conclusion, they said that there was an unknown risk of airborne transmission. Now, there have been some other studies published since that systematic review, and I think it's also very important to consider that if you're not going to give high-flow nasal oxygen, or if you're not going to give CPAP, non-invasive ventilation, what are you going to do other than intubating the patient? And certainly we would give oxygen. And this study looks at high flow versus other oxygen delivery devices. And the simple message is that high flow with flow rates of 10 to 60 litres per minute is no different to oxygen using a simple mask and flow rates of 15 litres a minute, a non-rebreathe mask 10 litres a minute. It's broadly similar and it's actually better than when you're using a Venturi mask. And I think it's very important that we remember this. However, note that this was using a simulator and smoke, and the particles were less than 1 micron. So that's all this study is telling us about. It is not telling us about what happens with droplets, which is actually what we might be expecting to be generated by these different forms of oxygen delivery. This is another study published in the Blue Journal. The technology that they used was able to pick up particles of 0.37 to 20 microns. So again, this is not going to be picking up droplets, it's going to be picking up the smaller particles. And basically what they showed was in a comparison of room air, oxygen via nasal cannula, a face mask, high flow, and they included non-invasive ventilation with these pressures, that it made no difference, that there was no increased dispersion of particles using these different modalities, which were similar. All of them were markedly less than when a patient coughed, and some suggestion that coughing with high flow or with nasal ventilation actually had a protective effect, and we'll come back to that again in a minute. They concluded that there was no difference between these different modes, but this was in healthy human volunteers. This study down here is another one that has been published recently. Well, actually, it hasn't yet been peer-reviewed, so that needs to be borne in mind. But the technology that they used was designed to pick up particles of up to 10 microns in size. And they showed similar particle concentrations with standard nasal cannulae at 6 litres a minute, a non-rebreathe mask at 15 litres a minute, and nasal high flow at 30 and 60 litres a minute during spontaneous breathing and coughing. But again, this is just picking up small particles, not the larger particles. In the paper, they said that this was the age range of particles generated by coughing, but I must say I don't think that's true, that coughing can generate large particles. One knows what happens, and particularly with sneezing, what one can produce. This is another very interesting study that has not yet been peer-reviewed. They used an imaging technique, the smallest detectable particles being 33 microns. And what we have here in this slide is the effect of nasal high flow on a voluntary snort. And in particular, if we focus on here where we have particles of up to 500 microns in diameter, you can see that the effect of nasal high flow at 30 and 60 litres per minute is to reduce the number of these size particles by about 50% compared to no therapy at all. So a suggestion here that actually during voluntary maneuvers such as coughing, sneezing, etc., that high flow might be protective. And the authors hypothesized that it would take 86 hours of quiet breathing with nasal high flow to produce the same number of particles as 1 minute of coughing with no therapy. So coughing is a very, very important aerosol and droplet generating procedure. Another issue that it's important to consider is this idea of nasal high flow being aerosol dispersing. And also it has been suggested that because of the higher flows that one is seeing, that it will actually reduce the concentration of viruses in whatever is breathed out. And what is shown here is just the person breathing, and this is the normal aerosol. If you put a suction catheter down and make them cough, you will get both more particles, but also they'll go further. And the same is true if you use a non-invasive ventilator with an exhalation port. It will blow the particles further. And there is some evidence to support this from David Huey's work, in that he showed that it was really important to have a well-fitting interface connection during non-invasive ventilation, and that when you had a patient receiving nasal high flow, that there was a jet of smoke going 620 millimeters laterally when the connector came loose. So again, suggesting that these high flows can actually disperse particles further. This is a very recent study that has only just been published in the ERJ Open Research. It's the early view. This is from Dr. Lee and colleagues looking at the effect of a mask on patients receiving nasal high flow. So what we have here on the left is just a comparison between conventional nasal cannulae and nasal high flow, looking at the concentrations at 1 foot and 3 foot, but again, look at particle sizes only up to 10 microns, so not telling us anything about larger droplets, but basically showing that if anything, nasal high flow results in lower concentrations than standard nasal oxygen. If you put a mask on, you see a significant reduction at 1 foot and a less marked reduction at 3 foot. So a suggestion that wearing a mask at the same time as having nasal cannulae in place may be beneficial. And importantly, in this study, they found no virus in the room, but it's important to note that this was a negative pressure room with frequent air changes, and so this would not apply if nasal high flow was being given in a different sort of environment. So that's all the basic data, the indirect data, suggesting that nasal high flow is no worse than existing therapies and in some ways may be better. But there are significant limitations in my view. What really matters is what happens in the real world. And there are now a number of studies reporting experience of nasal high flow, non-invasive ventilation, CPAP, etc. in COVID-19. Some, but not all, report the numbers of staff being affected by COVID-19. And these are the studies. Vianello et al., this was a study of 28 subjects receiving nasal high flow, and none of the staff had a positive swab to day 14. The Guy study was from France, 34 patients, 1 nurse contracted COVID-19, but it was thought that they'd got it from their parents. And that, of course, is always going to be a confounder. The largest study was from Italy, and this was, again, just a cohort study describing experience of CPAP, nasal high flow, and non-invasive ventilation in 670 patients. 42 out of 353 healthcare workers, 11.4%, picked up COVID-19, 3 of whom required hospitalization. This compares with 3.8% of the hospital personnel not looking after COVID patients. But really, the figure that we'd really like to know is what would be a comparable figure for the hospital personnel who were looking after COVID patients, but just on a general ward, those not receiving high-flow CPAP, etc. This last study from Patel et al. Is Jerry Kreiner's group in the US, 104 patients. They had 2 out of 80 healthcare staff coming back COVID positive. So what can we conclude? I think there's indirect evidence that nasal high flow is no worse than other modes of oxygen delivery, and we have to give these patients something. Indeed, it may be protective, particularly during coughing or sneezing, and maybe we should think a little bit more about what we're doing for our patients receiving standard oxygen and those who are not receiving any oxygen at all, but who are coughing significantly. It's difficult to be certain, but I think that infection of healthcare workers, which does not seem to be increased and perhaps might be lower than one would expect. I think certainly there's no room to change recommendations about wearing PPE, about when possible looking after these patients in single rooms. It's crucial to make sure that interfaces are fitted correctly, and patients should wear a mask if coughing, particularly if they're also receiving nasal high flow. And with that, I will conclude. We're now going to move into our Q&A session, and we're going to start really looking at Arnaud's presentations and talk about the use of nasal high flow in hypoxemic patients. And I'd like to start just with a comment, Arnaud, about the Italian study in COVID-19, and just to make the observation that although high flow seemed to be associated with a better outcome in terms of mortality, it's important to note that, first of all, this was not a randomized controlled trial. It was just a large series. And secondly, that if you look at the physiological data, the nasal high flow patients were actually not so severe in terms of their respiratory rate, their oxygenation, their SOFA scores, etc. So we just need to be careful about using that as a suggestion that nasal high flow is superior in that group of patients, because I don't think we're necessarily comparing apples with apples. I'd like to move on to, Arnaud, really this question of NIV versus nasal high flow, and in particular to focus on the FRAT study, which is the main evidence that we have in this area. The NIV group was NIV plus nasal high flow, wasn't it? So when the patients weren't on NIV, they were receiving nasal high flow. And the primary outcomes, there were actually no differences between the 3 groups. It was the secondary analysis, the post-hoc analysis, or the secondary outcomes that showed that nasal high flow alone appeared superior. But what this suggests is that a period of non-invasive ventilation is positively harmful for these patients because they were receiving high flow as well. So just be interested in your thoughts as to why that might be, because clearly it's a really important thing to understand when we're trying to decide whether we should be using nasal high flow or NIV in these patients.
You're right that the primary outcome was different, the rate of intubation in the overall population, but it's also true that rates were significantly lower in the most severe patients, meaning in patients with a PF ratio below 200 millimeters of mercury, and it was the majority of the patients, maybe 3/4 of correct. Patients treated with NIV received NIV alternating with high flow nasal oxygen between NIV sessions. So we have to remember the duration of NIV was 8 hours within the first 24 hours in the study. It's true that the difference of mortality is very high, nearly 80%, and I really think that the potential deleterious effects were due to these large tidal volumes, and we were very surprised to observe that large tidal volume, only 1 hour NIV initiation, were significantly associated with an increase in intubation rates and increased mortality rates. Maybe it's just because these patients were more severe than the others. It's true, probably these patients did huge efforts, strong efforts generating this large tidal volume. But usually tidal volumes are not used, for example, to decide intubation or to assess respiratory severity. I think this point is really new point or very interesting point for the future to better understand what's happened. Because, for example, in the previous studies on non-invasive ventilation, we are unable to know what were tidal volumes. It's very surprising. It's all previous studies on non-invasive ventilation, acute respiratory failure, de novo respiratory failure, volumes were not mentioned in the article as this point was not important. And but it's true that just a large tidal volume could be difficult to understand that just this point to increase such high mortality, but the other point was due to comfort, respiratory rate, improvement of dyspnea, and this point maybe together could have this potential beneficial effects.
I mean, I guess one of the problems that one has here is that one can measure the tidal volumes during non-invasive ventilation, but you can't measure the tidal volumes while the patient is receiving nasal high flow. Again, it's this question of NIV actually being harmful. And do you think that the high tidal volumes are being given inappropriately by NIV?
Maybe, but we can observe that pressure support levels are not very high, only 8 centimeters of water. I don't know what is the mean pressure support level used in the audience, but it's not a really high pressure support level. But despite this relatively moderate pressure support level, tidal volumes were relatively high. By contrast, it's true that we cannot measure high flow in tidal volumes generated with nasal high flow in clinical practice. Some physiological studies suggest that tidal volumes are not increased and even could increase resistance, and therefore NIV was not well adjusted, but even using pressure support level, the risk is increased tidal volume as compared to just spontaneous ventilation as with high nasal oxygen. And maybe because high flow nasal oxygen could decrease or mitigate larger volumes. But it's true that it's possible to really decrease tidal volume in patients with really huge efforts. And in this case, I think it's regardless strategy, it's impossible to limit the tidal.
Okay, I mean, I'd absolutely agree with you. That was my thought, was that the levels of pressure support were not really enough. It's something that clearly needs teasing out. And I think we need to be very cautious about interpreting this result in terms of the way that we go forward from here, because it is only one study, it is secondary outcomes, and it somehow just doesn't fit with the physiology to me. It's an unexpected finding. It's also out of keeping with what you presented in the other studies about post-extubation, post-operative care, etc., etc. So I think what we desperately need is perhaps some studies comparing just non-invasive ventilation with just nasal high flow and more big studies. But to move on, I think that the symposium is more about using nasal high flow. And some of the questions that have come through is, first of all, can you give some criteria for when you would start nasal high flow and what settings you would use in terms of flow and temperature?
Criteria in our unit, for example, there is no clear recommendation. But for example, in the FRAT study, we initiated nasal high flow in patients with a PF ratio below below 300 millimeters of mercury, but we saw that the main effect was a PF ratio below 200 millimeters of mercury, and also with patients with high respiratory rate, above 25 breaths per minute. It's very important because in other studies, for example, in the high study by Azoulay in JAMA, they mixed patients. Patients may have high respiratory rate, but also clinical signs of respiratory distress, a little bit oxygen. I think we need to start high flow nasal oxygen in patients with really acute respiratory failure, meaning respiratory rate probably above 25 breaths per minute, and hypoxemia, meaning with a PF ratio below 200 millimeters of mercury. This is my first response. And in the settings, we usually start with a flow at least 50 liters per minute, or maybe 6 liters per minute. I think we have to start with a high flow rate so that the higher the flow, the greater the reduction of warming and the greater the reduction of dyspnea and respiratory rate. And therefore, the initial setting should be at least 3 liters per minute of flow, and obviously FiO2 adjusted to maintain your targeted pulse oximetry. In our unit, we target pulse oximetry above 28. Therefore, it's very easy to adjust high flow with the first 24 hours. The most difficult is to decrease FiO2, decrease the weaning from high flow nasal oxygen, but maybe it will be next question.
It is indeed the next question. So that was when you start. So you've given us some oxygenation, some respiratory rate criteria, and a flow rate to start. Temperature, just very briefly before we move on to when you stop.
High flow could be using an open system, for example, Fish and Pickle or Philips, I know also with ventilators. And using ventilators, you have to use heated humidifier, and using open system, you also need to use heated humidifiers. And using this system, you can adjust usually to temperature and to provide best humidification, and the initial setting should be high temperature, 37 degrees. And it's true also that in some cases, patients may be uncomfortable in intubation, and this is a minority of patients, but in this case, it could be interesting to useful to decrease temperature around 33 or 34 degrees. Depends on what your system in your unit. There are several manufacturers, and it's different according to the system, but maybe decrease a little bit temperature around 33, 35 degrees.
Thank you very much. So now just to when you stop it, and the two situations in which you're going to stop it is either the patient getting worse or weaning the patient off nasal high flow because they're improving. And if just very briefly you could give us some criteria for that. When do you stop?
First situation in case of warning. This is the first situation. This is obviously the most complex one. As you know, several studies have suggested that delayed intubation could be a deleterious for patients, but this result has never been found in a randomized control trial. For example, in the FRAT study, the time to intubation was similar between standard oxygen, NIV, or high flow nasal oxygen. It's very important to be aware in the study, the FRAT study, there were criteria for intubation, pre-specified criteria for intubation, including high respiratory rate reaching 40 breaths per minute, or severe hypoxemia, meaning desaturation using to 100 beds. In the new study that we designed, we use again two criteria. The follows: respiratory rate reaching 40 breaths per minute, or severe hypoxemia, or oximetry between 90%, or PF ratio below 100 millimeters of mercury. And the other criteria: shock or altered consciousness, and the other organ dysfunction. By contrast, in case of patient improvement, we have few data to conduct a weaning high flow nasal oxygen. We recently published a small study, a single center study, meaning our experience, and we found that the best criteria to switch from high flow nasal oxygen to standard oxygen was only FiO2, and patients with FiO2 40% or below had a very, very high success rate of weaning from high flow nasal oxygen to switch to standard oxygen. Because it's true that in this situation, high flow is low and could be, in some cases, delayed discharge or switch to standard oxygen. Our best criteria could be only FiO2. We also assessed ROX index using pulse oximetry, respiratory rate, FiO2, but finally, this did not bring a better sensitivity or specificity, and FiO2 of 40% was easy and reliable criteria to be in high flow nasal oxygen.
Thank you very much, Arnaud. Now I move to you, Jens, and really, obviously, there's not so much literature about the use of nasal high flow in acute hypercapnic respiratory failure, and I'd really like just to focus on COPD. And while those studies that are in progress are obviously going to be extremely helpful in informing where we go, we're not there yet. And so my question to you, Jens, is when now would you be suggesting that nasal high flow be used in a patient with an acute exacerbation of COPD, if you would be suggesting that at all outside of a clinical trial?
I would do this if some patients have a poor tolerance of non-invasive ventilation in my clinical practice, and if we have a good non-invasive ventilation and we have very good and not so much problems with these patients in terms of intubation, I would try to use nasal high flow device. And I do it all the day in these patients. Perhaps they have a decrease in PCO2, but we have no studies with a control group. In terms of stable patients with an acidosis or non-acidosis who do not tolerate non-invasive ventilation, I would prefer to use a trial with nasal high flow.
What I heard you saying was that basically NIV remains the standard of care, but in somebody who is poorly tolerant of NIV, nasal high flow is a very reasonable alternative. There's one final question, which is about the use in the post-operative patients of nasal high flow, really as a way of controlling upper airway obstruction. And Arnaud, this is probably a question for you. For a post-operative patient with obstructive sleep apnea, the example that has been raised is somebody who had a tonsillectomy, for instance. And what's the pressure that you get from nasal high flow to control upper airway obstruction?
I don't have any data about this. And it's true that as Jens, I think how could be interesting in patients with chronic obstructive pulmonary disease, but we don't forget that pressure and CPAP, at least 5 centimeters of water using non-invasive ventilation is the best treatment for patients with really obstructive apneas. And in this case, I'm not sure that high flow nasal oxygen is enough to reverse for apneas. And these patients, post-operative patients, had high risk of apneas. They should be received non-invasive ventilation, and I'm not sure high flow is enough to.
There isn't any evidence, and that CPAP would remain the preferred modality in people with significant upper airway obstruction. So I think that we should draw this to a close, and I would just like to thank, first of all, Philips for organising this, and secondly, both you, Arnaud, and Jens, for your excellent presentations. Thank you very much indeed, everybody, for your time.